We are joined now by Dr. Sarah Prager. Dr. Prager, it's great to see you today.
Thank you. Nice to be here.
So you're giving two talks at this year's ACOG, and they're both on pregnancy loss.
Yes.
Why is this such an important topic to discuss?
There are a couple of reasons why I think it's such an important topic. One is that, especially in the first trimester, pregnancy loss is actually incredibly common, but it's not often talked about. And I think many women aren't even aware that other women have had other losses until they have their own, and then they find out that many people they know have also experienced something similar. The other reason is that I think management of pregnancy loss is often confined to certain avenues, and there are actually a wide variety of ways that pregnancy loss in the first and the second trimester can be managed, and that's really what I'm going to be talking about today.
Well, why don't we talk about the first trimester? What are some of the things that you want members to know and understand about managing it?
Well, I think the most important thing that I'd like to convey is that much of pregnancy loss in the first trimester can actually be managed outside of an operating room. So there are 3 different main ways to manage pregnancy loss in the first trimester: expectant management for women who just want to watch and wait and see, and also using medications, which essentially induces more rapidly that passage of the pregnancy tissue, or doing a uterine aspiration, which just empties very quickly in a procedure the contents of the uterus. That procedure portion, however, can happen both in an operating room or, most commonly, in an office setting. And I think one of the things that is so important to talk about is that women often have very clear ideas about how they would like their miscarriage to be managed.
Okay.
And in the absence of a real contraindication, I think it is completely appropriate and is extremely safe to use whatever method they're interested in using.
But it's up to the physician to talk to the patient and listen.
That's
right?
exactly right. So using some shared decision making and patient-centered counseling, asking some open-ended questions and asking some questions about what their values are around this process are extremely important. And pregnancy loss is a situation where women really feel very powerless oftentimes. This is not something they were anticipating. And so being able to give them some options, some agency to make these decisions can be incredibly empowering and make it not quite such a terrible experience.
Is there also the aspect of emotional support in this situation that needs to come from the physician?
Absolutely. So the physician can be a huge emotional support in this setting, but also bringing this procedure and this process into a clinic setting and outside of an operating room also opens up other options, like having a family member or a support person be present for that process as well.
So now let's talk about second trimester. That brings different challenges. Talk to me about that.
Second trimester loss, I think, is challenging because a lot of times many places don't actually have access to surgical management in the second trimester. So surgical management and medication management are both options, but you have to have a skilled practitioner of D&E essentially available to do that. And because of the not just similarity, but exact similarity of the procedure with elective abortion, there's a lot of times stigma surrounding that, or just not anybody trained. And I think we're really lucky in the United States. We have a fellowship that now trains specialists in second trimester pregnancy and family planning in general, and that can be extremely helpful for increasing the number of providers who can then effectively offer both medical and surgical options in the second trimester.
So that really is a huge challenge. But what about, is there another big challenge facing physicians? What kind of solutions can you offer to help them?
Again, I would just fall back on patient-centered care and shared decision making.
Okay.
I think both, again, in the first and second trimester, physicians make a lot of assumptions about what the patient might want. And so we really have to check our instincts about what we think we would want in that situation and really let the patient express what her needs and desires are in that situation and be as open as we can to helping her fulfill the management in a way that is appropriate for her.
Excellent. Dr. Prager, thank you so much for joining us today.
Thank you.
ACOG TV has all the coverage you want with the big events and key newsmakers. Be sure to check out our content, which is updated each day here on YouTube from the ACOG 2019 meeting here in Nashville.